Hello, everyone, and thank you so much for joining us tonight for the third webinar in our Spring Sports Series presented by Rothman Orthopaedics and NovaCare Rehabilitation. This is the running edition of our series where we have Dr. Daniel Fuchs, Zach Roberts, and Kelly Johnson presenting uncommon running injuries, how to diagnose, treat, and prevent. We have 3 clinicians presenting to show you how the sports medicine team work together to expedite the injury process. I'll let Natalie introduce Dr. Fuchs, and then I'll introduce our team.
Yeah, thanks everyone for joining us. My name is Natalie. I work at Rothman Orthopaedics in our marketing and physician relations department. And Dr. Fuchs is an orthopedic surgeon here at Rothman, specializing in the treatment of foot and ankle disorders. He treats all foot and ankle conditions and has particular interest in sports-related injuries, acute fractures of the foot and ankle, as well as bunions, hammer toes, foot and ankle arthritis, diabetic foot conditions, ankle arthroscopy, complex deformity, and total ankle replacements. Dr. Fuchs sees patients at our Bensalem, Chalfont, Doylestown, and Willow Grove offices, and he operates at Rothman Orthopedic Specialty Hospital in Bensalem and Abington Hospital as well.
Zach Roberts is our center manager at the Chestnut Hill location and has been with NovaCare since 2016. Zach is a certified orthopedic clinical specialist and board certified athletic trainer. He treats a variety of orthopedic and neurological conditions, specializing in sports medicine, post-operative orthopedic surgeries, vestibular conditions, manual therapy, and work-related injuries. Kelly Johnson is a certified athletic trainer. She received her bachelor's degree in athletic training from Westchester and her master's of science for athletic training from Old Dominion University. While at ODU, she completed a research study regarding rehabilitation with a chronic ankle instability and served as the athletic trainer for Norfolk Christian Schools. In the fall of 2020, she moved back to Southeast PA and started with NovaCare as an athletic trainer for Faith Christian Academy and is now serving at Renaissance Academy Charter School. And without further ado, I'll hand it over to Dr. Fuchs so he can start.
Thank you. Let me share the screen. All right, that coming up all right? Great. Yep. So thanks for the opportunity to speak. I'll be talking on running injuries, focused on the foot and ankle area as my area of specialty. So go through an agenda, go through kind of 5 major foot and ankle injuries related to running. The first is kind of a category of, forefoot and metatarsal area that includes metatarsal stress fracture, metatarsalgia, Morton's Neuroma, and then we'll also talk about Hallux rigidus, plantar fasciitis, Achilles tendinitis, and ankle sprains. So really, the majority of these are kind of overuse type of injuries that you'd expect with repetitive activity like running, which puts a lot of stress through the foot. And then, ankle sprain is kind of a little bit different in that it's more of an acute injury, but certainly can be an issue for runners who, run on various surfaces. So first, for metatarsal stress fractures, this is an overuse type of injury, and it's characterized by pain and most specifically swelling at the top of the foot. In the absence of swelling, it's unlikely to have a metatarsal stress fracture or any other type of stress fracture. The most common bones involved would be the second and third metatarsals. And on initial treatment, the x-rays may or may not be fully diagnostic. Sometimes you can see a sclerotic line, or if the issue has been going on for a little while, you might see some periosteal reaction, but oftentimes you won't see anything, and then may develop the healing response evident on follow-up x-rays, like we see in this x-ray on the right side, where the second metatarsal has kind of an abundance of bone around the area where the non-displaced fracture has occurred. If the diagnosis is uncertain, an MRI is a much more sensitive test than an X-ray to rule out or to evaluate for a subtle fracture. So the treatment for this is similar to many of the other injuries. It's really activity restriction, and that's I know a particularly difficult thing for runners who are it's tough to get them to slow down. But for this, really, that's what's required. to stop running for a period of time and even to immobilize if there's still pain with walking in normal shoe wear. This type of short fracture boot is appropriate for most metatarsal stress fractures. Ultimately, modifying shoe wear using a little bit more supportive, stiffer shoe, as well as potentially orthotic inserts to stiffen the shoe are effective. In the rare cases that these don't heal with the appropriate rest, other treatments could include use of a bone stimulator, pictured here, or surgery, where we would apply a plate and screws and possibly add bone graft to get the fracture to heal if it doesn't heal on its own. Again, most of these will heal with non-surgical treatment and rest and immobilization. Going on to metatarsal, this is kind of more of a general term for pain at the metatarsal head area. So the forefoot area, including at the bottom of the foot, as seen here. The calluses that develop can contribute to the pain. And really what's going on here is it's another repetitive type of situation where runners are getting force through the metatarsal heads, or basically the ball of their foot, at an increased force compared to normal population. And that could occur for a number of reasons. It could occur due to the running mechanics, due to having a tight calf muscle, due to having some forefoot deformity such as hammer toes or contractures of the metatarsal phalangeal joints, the joints between the foot and the toe. You could also develop wearing or tearing of the tissue that connects the toes to the metatarsal, called the plantar plate, and that can manifest as metatarsalgia as well. The treatments are similar. Number one, treat the underlying conditions, the hammer toes, the plantar plate injuries. In addition, using an orthotic such as a metatarsal pad, viewed here, where kind of more evenly distributes the forces so they're not so concentrated on the metatarsal heads is affected. Taping or splinting the toes if you do have a deformity at the toes or the metatarsal phalangeal joints, as well as, again, immobilization and resting. Calf stretching exercises can help most of these problems that occur at the forefoot. By loosening up the calf muscle in the Achilles, it puts less force through the front of the foot with each of these steps, of which obviously there's many in the situation of a long distance runner. And then surgery, again, not commonly required and somewhat of a last resort, but can include metatarsal osteotomies. In this case, this is a patient with a significant deformity of the forefoot, including hammer toes and head. Metatarsal osteotomies to shorten and elevate the third, fourth, and fifth metatarsal heads and stabilize each with a single screw. Morton's neuroma is again another condition in the same general area of the forefoot. It involves a thickening and irritation of a nerve, interdigital nerve that runs between the metatarsals and between the toes. Patients get pressure on the nerve between the metatarsal heads and the transverse metatarsal ligament seen here in this diagram. This is actually most commonly between the third and fourth metatarsals, next most commonly between the second and third. Can be related to trauma or basically repetitive microtrauma. Patients will have tenderness at the web space, a painful palpable click when you squeeze the forefoot together. And they typically will have the most pain with really tight fitting shoes. They'll feel burning that can radiate into the toes, as well as numbness and tingling. So treatment, first thing is to find more comfortable and appropriate shoe wear, a shoe with a wider toe box, and to accommodate and prevent those metatarsals from squeezing that nerve. That metatarsal pad that was shown in the section on metatarsalgia is effective for this, as well as are the calf stretching exercises. If that's not affected, this is one of these conditions where a corticosteroid injection can be very helpful to kind of calm down some of the inflammation, some of the swelling in the nerve, and try to break the cycle of repetitive nerve thickening and resulting more pressure that continues on itself. And then surgical excision is the last resort in patients who either don't respond to an injection or respond but have a recurrence of symptoms, and actually involves not just decompressing the nerve, but the most reliable way is to actually remove that nerve. So it does result in some numbness, but is very effective at relieving the pain. So moving on to kind of a separate category, great toe arthritis or Hallux rigidus is something we see with runners really, more over the long term. And it doesn't only happen in runners, but oftentimes when patients come in, for this problem and you kind of delve into the history, you find that, at a high rate, people do tend to do some running. So these are this is where you get arthritic changes that occur at the first metatarsal phalangeal joint, which is again between the foot and the great toe. And you really get kind of two components of the arthritis that we have to treat each of them. There's cartilage loss in addition to the formation of bone spurs, which is really the body's response to damage to the joint in order to stabilize the joint, but results in more stiffness and can result in impinging pain as well as painless shoe wear. So you get pain from the bone-on-bone contact as well as the impingement of the bone spurs on themselves and with the shoe wear. So you can experience pain deep within the joint that typically occurs with activity, and also at the top of the foot where you get the bone spur rubbing against shoes. So back to the treatment options, shoe wear modification once again. In this case, you really want a stiff-soled shoe with a high toe box, so you're not getting direct pressure on that bone spur, and a shoe that has kind of a soft upper portion that doesn't put a lot of pressure. You can insert a carbon fiber insert into the shoe beneath the insole to artificially stiffen the shoe. Activity modification, slowing down on the running, at least temporarily, taking some anti-inflammatories, ice, typical arthritic type treatments are also effective. Surgical treatment, there's a few, for more mild cases, a bone spur removal and cleanup of the joint, and the fancy term for that is a chylectomy, and joint debridement is an option that preserves the range of motion, but removes that bone spur that's contributing to the symptoms. For more advanced disease, a fusion sometimes is needed, where you actually remove the joint entirely and hold the bones together with a plate and screws while the body fills it in with bone. And even though this talk is geared towards runners, I mean, people, there have been pretty good studies that show that patients can actually run after first MTP fusion, and they're more likely to have an improvement in their ability to run rather than the opposite. The last thing I'll mention is something called the Cartiva implant, which was a little bumper to help try to restore the joint space. There's a lot of enthusiasm for this, but some of the more recent results coming out are somewhat inconsistent. So kind of reserve that for very specific indications. So moving on to ankle sprains, this is again kind of a little different in that it's an acute injury and very common, where epidemiologic studies show that these are occurring at a high rate, and that's what we see in reality as well. It can, a sprain, not everyone realizes, involves a ligament tear. It can be a partial versus a complete ligament tear, and typically, or most commonly, recurs from an inversion type mechanism, rolling the ankle. Ligaments at the outer aspect of the ankle are most commonly injured. The anterior talofibular ligament, the calcaneofibular ligament, as seen here on this diagram, are the most common ligaments involved. And there's a variation in the severity in terms of the number of ligaments and whether they're partial or complete. Most people get better from these, but if they're not treated properly, there are cases that go on to develop chronic instability and development of post-traumatic arthritis. Sorry, 1 second. Jumped around a little here. So as far as the treatment, initial treatment is almost always non-surgical. There's not really a great indication for acute surgical treatment for an ankle sprain. It's always a matter of resting. If it's a severe sprain, going into what we call a fracture boot. In this case, it's a tall fracture boot, and then ultimately transitioning to a lace-up ankle brace. And then, getting involved in physical therapy for mainly peroneal tendon strengthening, stretching exercises, and proprioceptive training, really to restore strength, to improve the dynamic stability of the ankle, and prevent re-injury and reduce the chances of going on to a chronic instability situation. Surgical treatment really reserved for patients who have persistent pain or instability or recurrent episodes of instability. This can occur in up to 50% of patients, but I think that's probably a high estimate. It's probably lower than that. There's various techniques to do this. Modified Rostrum-Gould is a common one that's been around for quite a long time. And you see this article from 1980, but it involves advancing and tightening these ligaments, the anterior talofibular ligament and the calcaneofibular ligament. However, we have had some kind of more recent advances, such as the use of the internal brace, which uses this heavy suture tape material to reinforce the repair, increase the rate of return to sports, and reduce the risk of re-injury. So on to plantar fasciitis, which typically manifests itself with pain at the bottom of the heel occurring from the degeneration of the plantar fascia, which is a strong ligament that goes all the way from the heel or the calcaneotuberosity to the toes. This is probably the most common thing coming through our offices as far as foot and ankle conditions. Runners can get it, but really anyone can get it. It's just throughout the population. Pain occurs mainly right where the plantar fascia attaches to the calcaneus, but you can, less commonly, get it kind of at the mid-substance of the ligament itself. Patients will often report pain with first steps in the morning, in addition to prolonged standing or impact activities such as running. And while this is not, there's not a significant structural abnormality here, the pain can be quite severe. Patients describe a sharp stabbing pain, like an ice pick is being stabbed into the bottom of their heel. So it can be very limiting in terms of their function. There can be a bone spur at the heel, but this hasn't been shown to be actually the cause of the pain. Treatment again is mainly or almost entirely non-operative. This tends to be a self-limiting condition and very rarely requires surgery. So first-line treatments are just self-directed stretching of the calf and plantar fascia. You can apply ice and massage the area. I tell patients to fill a water bottle and freeze it and roll it along the bottom of their foot. Soft cushion heel pads are helpful. Custom orthotics aren't required. I tell people to avoid barefoot walking and then to rest to some extent. Second line, corticosteroid injections or formal physical therapy. I like to wait at least 3 months for a steroid injection because there is some risk of weakening the tissue and causing a plantar fascia rupture. And then again, last resort is surgery, which can involve partial plantar fascia release of the a nerve that runs in the area that can be contributing to the symptoms, and also a calf lengthening procedure if the calf's tight and unable to be adequately stretched with self-directed stretches or therapy. Some newer technology includes a percutaneous needle tenotomy. Different companies make something like this, and it's more of a minimally invasive procedure that can have some of the similar effects of surgery without quite as much of a open exposure. So Achilles tendinopathy is our last condition. This is there's a wide range of conditions, and the most common is probably just a pure tendinitis or an inflammation around the lining of the tendon. However, as this progresses, it can turn into a degeneration of the tendon itself with prolonged overuse. This can occur both at the area where the tendon inserts on the heel or several centimeters above, and we kind of break that down into insertional versus non-insertional Achilles tendinopathy. It has been shown to be related to tightness of the tendon and the attached muscle unit, which is the gastrocnemius and the soleus. And pain occurs with activity or with walking after a period of immobility. People often describe after a long drive, getting up and trying to walk, they'll have a lot of pain, or getting up in the morning again. Clinically, you'll see thickening of the tendon as well as swelling of the surrounding soft tissues, and those are kind of two independent things. And when the tendinopathy occurs at the insertional level, as like seen on this this image here, it's often accompanied by a bone spur at the Achilles. We'll see an X-ray of that. But non-operative treatment, a period of immobilization, particularly if patients are having a significant limp with normal day-to-day activities. Ice, anti-inflammatories, calf stretching exercises, once again, are helpful. And then for this, physical therapy is really, in studies been shown to be very effective at relieving this problem and avoiding the need for surgery. So eccentric stretching and strengthening exercises, or Alfredson's protocol, based on an author who described this, as well as use of a small heel lift in the shoe, which tends to offload the Achilles somewhat. If this comes to having to require surgical treatment, In the case of an insertional tendinopathy, it involves detaching part or all of the Achilles tendon in order to access this bone spur. And there's multiple different parts of the bone spur. We call this area here the haglins, as well. Here's the insertional osteophyte, and then there's some calcification within the tendon. And we take the tendon off and then are able to remove that entire bone spur, remove the diseased portions of the tendon, then reattach it down to bone using suture anchors and even transferring tendons if needed to augment the repair. I think that wraps up what I had prepared for the most part. Some of the take-home points here, there's a number of different conditions that runners can get, largely due to repetitive overuse, but can have some acute injuries. And by and large, these are all initially treated with non-operative means, with initial mobilization and rehabilitation. Surgery is rarely required, but is considered an option when the other treatments are ineffective. And one thing I didn't mention, but a lot of people asking, when is the time to have surgery? The decision should be, based on the limitations, the pain, the lack of function that you're having at the time, rather than trying to prevent something or foresee something happening in the future. And I think that's helpful in making the decisions. Thank you.
All right. Thanks, Dr. Fuchs. I was going to highlight the role the physical therapist plays in the sports medicine team. Kelly, if you can pull up the slide for me. I'm just going to review sort of the process or the sports medicine pathway, and then go over what to expect from your physical therapist in relation to running injuries, and then just highlight a couple of the most common treatment strategies or common treatments that are given by physical therapists, and correlate those to the 5 common injuries that Dr. Fuchs had just kind of reviewed for us. So Kelly, if you can go to the next slide. So this slide is just highlighting our sports medicine pathway. Obviously, the best way to rehab or fix an injury is injury prevention, not have the injury occur at all. This typically occurs during the off season or in the preseason training, and our athletic training staff, strength and conditioning professionals, and coaches typically implement these programs to help at least reduce the incidence or the risk of injury throughout the season. Of course, injuries are going to occur. There's sort of no way around it when we're playing different types of sports, especially with running, being that it's such a repetitive activity. So the initial step is going to be reporting that injury to your athletic trainer, letting them perform their initial on-field assessment, be able to triage, determine the severity of the injury, and make the recommendations, whether they want to treat it in-house or if they feel like they need a little bit more expertise and refer out to somebody else. So typically that's going to be step 2. We're going to go refer to the team physician or their orthopedic. The orthopedic, as Dr. Fuchs just went through, is going to do their thorough examination and determine whether they want to do a medical management or conservative treatment options, versus whether surgical intervention is going to be necessary. So if they determine medical management or conservative is more appropriate, typically you'll wind up seeing yourself go to physical therapy, formal physical therapy, and have some one-on-one specialized treatment. This will give us the ability to perform our own evaluation examination on the athlete and determine what the best plan of care is in terms of rehabbing back to their prior level of function. If rehab goes well, typically we're going to do some type of return to sport testing. This can be done by either the athletic trainer or by the physical therapist in the clinic. If all goes well and the athlete's showing that they can withstand or tolerate their typical stresses from their sport that they play or from running or distance-wise, we'll typically refer back to the orthopedic. Orthopedic can sort of give the clearance to return to sport. So if all goes well, we're planning on reintegrating that athlete back to their competition, their distance, whatever the case may be. And they're going to work pretty closely with the athletic training staff and the coaches in terms of reintegrating into practice first and then getting back into their specific competition. So this just gives a quick highlight or quick synopsis of what the athlete should expect from initial injury all the way to return to sport. Obviously, it's going to be dynamic, it's going to be fluid, and each step we can have communication along the way between the athletic trainer, physical therapist, and the orthopedic in charge of the case. So we'll move on to the next slide here. This is just kind of going into my role as the physical therapist in the sports med team. My goal here is to restore a prior level of function and return the athlete back to their typical activity as quickly but as safely as possible. So what you should expect from your initial physical therapy visit is a thorough examination one-on-one. They should be going through a detailed medical history / history of injury to determine cause, severity, those types of things. And they should be looking at a biomechanical screen initially, looking at foot posture index, foot positioning, bony abnormalities, malalignments, and postural positioning as well, amongst some other things. They should then get into some range of motion, strength testing, flexibility testing, and special tests, just to help them rule in and rule out certain things that are going on and get an idea of maybe some contributing factors to why the injury developed in the first place, whether it's acute versus chronic. If the injury is more chronic related, where there's no actual mechanism of injury, or it's more kind of a repetitive injury, there should be a running analysis done, typically getting them on the treadmill and taking a look at their running mechanics and their gait cycle to see if there's any specific abnormalities that might have led to the repetitive stress or abnormal stress or unnecessary stress to the joint or soft tissue. And we should be looking at your footwear and your running surface as well to cue us in if those are some external factors that are leading to injury as well. This will kind of give us a good baseline of where the athlete's at and where we feel they can achieve goals based on their severity of injury at the time of the initial evaluation. So the next two slides here are just going to basically give you some insight into some common physical therapy treatments. There's obviously a ton of different things that the physical therapist is going to do. I don't have enough time to go through all of them, but I'm going to just highlight some of the common ones that you might experience specifically related to those 5 common injuries that Dr. Fuchs went through. So manual therapy techniques are pretty common, especially early on in the rehab process, and they're meant to help reduce pain and start to mobilize soft tissue and regain range of motion and normal joint mechanics. So one common one that you'll most likely a physical therapist would work with you is joint mobilizations. These are skilled graded forces to move a joint in a desired direction, and they have different graded forces behind them based on how they want to manipulate the tissue or the joint themselves. So these would come into play with Hallux rigidus. And this would help to get the great toe joint moving again and try to restore some of those normal joint mechanics. You'd also see these in ankle, used within the ankle, the talocrural joint. Oftentimes, stiff ankle joints can lead to plantar fasciitis or be a contributing factor to the development of plantar fasciitis and Achilles tendinopathies, and as well as chronic ankle sprains. As Dr. Fuchs had mentioned, getting ahead of it with ankle sprains is very important. If they hang around or not properly treated, oftentimes you'll develop chronic ankle instability and you'll have some problems down the road. So making sure that we have our hands on that ankle joint and restoring full motion is pretty critical for return to sport, especially with running athletes. Another common manual therapy technique that might be used is instrument-assisted soft tissue mobilization, otherwise known as ISTM. And it's a treatment for myofascial restrictions. Specially designed instruments are used to provide a mobilizing effect to scar tissue and myofascial adhesions. They're typically stainless steel blades that have a smooth beveled edge. They just allow the therapist to get into the soft tissue a little bit deeper. You'll typically see them used with tendon related injuries. They help to increase circulation, blood flow, and they also help to break down scar tissue, as I mentioned, and help restore normal tendon gliding and soft tissue function, essentially. Move on to the next. And then one of the biggest things that physical therapists do is provide exercise or prescribe corrective exercises to help restore normal functional mobility, normal movement, and help them kind of ease their way back into their normal gait mechanics, running mechanics, whatever the case might be. So a couple of the common things you may see related to those common injuries is eccentrics. So eccentrics are a muscle contraction that occurs when an external force is applied to the muscle, exceeds the momentary force provided by the muscle itself, resulting in the force lengthening the muscle tendon system while contracting. So essentially, these are negatives in strength training terms, and they are very effective at building tensile strength in the tendon. They also help to promote and improve control of the tendon and around the joint, and they help to mimic more of the stresses that are placed on the soft tissue or mechanical stresses placed on the soft tissue in running styles and other type of closed chain activities. They have great research behind them for most tendon issues. Achilles is the most studied, and when implemented correctly in rehab program, they're normally going to give you your best results. Another common treatment option that's given is proprioceptive activities. Proprioception is perception or awareness of the position and movement of the body in space. And balance activities are some of the exercises you can think of when we bring up proprioception. They are pretty critical with running athletes because most of the running mechanics are spent in single leg stance, which requires a significant amount of control to help reduce unnecessary stresses from ground reaction forces and unnecessary stresses from lack of control and the joints moving in places they shouldn't go, or decreasing sort of the biomechanical efficiency of the running cycle. And then we'll go to the next slide. And hip and core strength and stability. This should be kind of a staple of any running program. Typically, the same thought process with proprioception is that you're in a single leg stance most of the time, and it requires a significant amount of control. So hip and core stability is the capacity of muscles of the torso to assist in maintenance of good posture, balance, etc., especially during movement. Hip core stability has been linked in the research to injury prevention, actually, especially when it comes to lower extremity injuries with knees and foot and ankle pathologies. So they are great to implement not only in the rehab program, but also in our prevention during off-season or preseason training. So this pretty much just gives us a quick highlight, quick synopsis of some of the things you should expect from the physical therapist in terms of returning to your sport. Obviously, there's a whole host of other exercises and activities that can be implemented based on how the athlete presents to the physical therapist, such as different types of strengthening, stretching programs. Those are all things that we could potentially get into down the road. My contact information is on here too, so if anybody wants to talk about more in-depth things, feel free to reach out to me. So that's all I had prepared. I'll pass it over to Kelly to talk about her role as a certified athletic trainer.
All right, let me share my presentation real quick. All right, so as introduced earlier, I'm Kelly Johnson, and I'm an athletic trainer here in the greater Philadelphia area. And my job today is to describe the athletic trainer's role when dealing with running injuries. Obviously, we're the people that are on site most of the time when injuries happen. So we're the first line of defense in identifying and treating injuries. So I'm going to go over reporting to your athletic trainer and what an on-site evaluation may look like, that orthopedic referral process based on our evaluation, return to play once you received clearance, and then the most important injury prevention aspect and how we can go about that. So, as I said, athletic trainers are going to be your first point of contact when an athlete suffers an injury. So when any type of injury is suspected, whether it be super simple and is just something that doesn't greatly affect performance, but is causing enough worry to report it, please bring it to your athletic trainer's attention. That allows us to kind of get ahead of it and prevent any further damage. But it can also be something as severe as something that happened while you were running that caused immediate disability and needs to be addressed right then and there with a referral on site. Anything between these ends can also be reported. We really just want everything and anything to come through us. That way we can make sure our athletes are performing at their best. We also strongly recommend that parents and coaches report any suspected injuries in athletes. Athletes, especially the younger ones, tend to avoid admitting when they're injured because they don't want to miss time. So as a coach or parent, you may see something, a decrease in performance, limping while they're at home, but not when they're at school, or anything like that. Please report that to the athletic trainer. That way we can complete the eval and get down to the bottom of what's actually going on. So the basic parts of an evaluation are going to be our subjective and objective portions, and those help guide if we decide to treat in-house or refer. Most of our evaluations as athletic trainers occur on the field, out at practices or games, but we do commonly do in-clinic evaluations On field are typically a little briefer. We're simply looking at their functional ability and if they can return right then and there, or if we need to bring them in for a more in-depth evaluation or further referral. So the subjective portion is basically what the athlete can tell the athletic trainer about an injury. It's that series of questions that every athlete gets once they come over to the athletic trainer that can be pretty brief, or it can be a super long conversation, as long as we get to the bottom of what's going on. The first question is going to be, what's bugging you, or what brought you in today? And we're going to look for a mechanism of injury, or what happened. If there's no defined mechanism of injury, that's when we're going to lean more towards chronic conditions, where if you can tell us exactly what happens, that points at acute. We'll then go into a deep dive into pain, where we look at the location of the pain, if it's a specific spot or a broad region. The type of pain, as we spoke about earlier, is it a sharp stabbing pain? Is it a deep ache? Is it tingling, numbness, or a type of fullness? That can help differentiate pathologies. And then the severity. This is your typical 0 to 10 rank. Is it a 0 where you have no pain at all? And a 10 is as severe as it can get. We'll then also take a detailed medical history. Mostly we'll focus on injuries you've had in the past, whether you've injured this limb before, had similar injuries, or even non-similar injuries, but those pains felt very similar. So for example, if you broke your arm once and this pain is identical, it could identify some sort of fracture. We also will ask female athletes about their menstrual cycle, if they have normal menses, because that can identify some issues that could lead to more chronic conditions. We'll also ask male and females about their diet or medications they take. And then we'll take a medical history of the family to see if there are any conditions that run in their family. Once we've completed that, we can kind of compile a list of possible conditions and then get down to our hands-on or objective evaluation. The first main thing we're going to look at is deformity. If there is a deformity, this obviously signifies some sort of emergency where we're going to refer right then and there. We'll also check for circulation and pulse to make sure that there are no underlying conditions that we can't see that are causing severe issue. From there, once we determine there's no major deformity, we'll look for discoloration, any redness or bruising, swelling, and then we'll move on to palpation. Palpation is when we intricately feel for different structures along the area we're talking about in order to see what structure is involved. For example, in a lateral ankle sprain, which is what is represented in this bottom image, what we see is the discoloration and swelling down closer to the heel. However, the injury itself is up closer to the top arrow. So when palpating, we have to make sure we cover this entire area to make sure we're not missing anything, because you would typically expect the pain to be under the bruising, but in a case like this, gravity has pulled that down. So we're seeing two different regions of possible involvement. We'll also complete all of these tests bilaterally on the uninvolved and the involved limb. That way we get a baseline of what we're looking for. Then we'll complete more functional testing, which is going to be our range of motion, both active and passively, any strength training or ability to resist forces, and then special tests, which indicate specific structures that are involved and are tailored to what you find in your evaluation. Once we've completed both of these portions and have come up with a possible diagnosis or a list of a couple diagnoses, we're going to decide if we can treat in-house as just the athletic trainer, or if there's a need for a referral to an orthopedic or specialist and a need for further physical therapy. Most injuries, when we first get them, as long as they are minor acute injuries or chronic injuries that are first-time occurrence, or we notice that there's a treatable cause, like something like improper footwear or a move from turf to grass to concrete, we may address that in-house with just the athletic trainer completing some basic rehabilitation. However, if with this in-house improvement, when in-house treatment, we don't see improvement. If it's a moderate to severe acute injury, like those higher grade ankle sprains Dr. Fuchs mentioned earlier, or a repetitive or increase in severity in a chronic type injury, these are going to be more likely to be referred. These can be your late stage tendinopathies, anything that may require surgery, or things that you just aren't seeing improvement in with basic treatment. Once I have referred out to an orthopedic or the athlete has gone through physical therapy and has been cleared to return to play, that's when they come back to me and we begin the return to play protocols. So your doctor said you can return to play, now what? The first major step is that you turn in a note to your athletic trainer that says you are cleared. If they don't have that, they cannot begin any of your return to play protocol. So once we have that and complete your basic functional testing of your sport, we can begin a gradual return to practice. Most of these will be partial practices at first in order to see what you can do symptom-free. And then as you can do more and more symptom-free, we'll work back to full practices. This includes a lot of coordination with coaches in working athletes back, but it's super important that we take time and do not set a timeline for something like this, but instead work based on the athlete themselves. No athlete and injury are the same, so we have to make sure that we're taking the proper time in this return and not trying to rush things and then end up have the athlete suffer more injury after that. And now the most important part is injury prevention. As athletic trainers, we do get to build a special relationship with athletes where we are on the field for games and practices, and we get to see almost their everyday life and what possible factors could be leading to their injuries. We get to see what footwear they wear to school, what they're doing when they're walking around school, what they're doing on the field, and what they're doing during games that could be leading to these major risk factors. The risk factors that we're typically going to address with our plan, our plans we're doing here are going to be your intrinsic risk factors. There are extrinsic risk factors, which I mentioned, such as surface or shoe wear, but the intrinsic risk factors are more addressed with the physical therapy and preventative plans. So these are what are going to be addressed more by your athletic trainer and preventative plans. A few of these that we commonly see that lead to lower extremity injuries are going to be your muscular weaknesses or imbalances, severe lacks of flexibility, decreased postural stability in the core and pelvis, poor muscle reaction time, improper gait mechanics, a previous history of lower extremity injury, high BMI, and a low cardiovascular ability that commonly leads to early fatigue and thus form decreases. With our preventative plans, we have a couple main goals that kind of carry across all of the PEPs we're going to create. The first is obviously to reduce any injury occurrence by minimizing any vulnerable positions that the athlete may get into when completing activity. For those athletes that we have reporting any pain, we want to minimize that current pain and continue to work on stopping any further issues. And by addressing these first two, we're then able to keep athletes in the game and minimize the number of missed practices, games, or activities. And then our last goal is obviously to optimize performance and have the best possible athlete out there. So we're going to focus on flexibility, strength, power, agility, and any other sport-specific tasks that may be related to that sport. A couple examples of pre-made preventative exercise plans that we commonly see out there today are the FIFA 11 Plus, which is a soccer-based rehabilitation plan that has an 8-minute running section at the beginning, about a 10-minute strength, plyometric, and balance section, and a 2-minute agility section at the end. This is commonly the warm-up you see athletes performing on the sidelines before a soccer game or any sort of sport like that. And then your Santa Monica ACL plan, which is very similar, but is tailored more specifically to female athletes and involves active warm-ups and cool downs stretching, strengthening, plyometrics, and agility. These plans are both commonly referred to as soccer plans, but they are commonly used in lacrosse and field hockey and even football and basketball, as they can easily be tailored to those activities. Simply putting a lacrosse stick in somebody's hand while they're completing the agility drills, or adding a shooting goal at the end of that. Those are very easily altered to whatever sport you want, so it's easy to customize. And then finally, this is the main 4 categories that we address when we set up an individualized preventative exercise plan. Stretching is not on here, but it is one of the most important. We're going to focus on calf stretching and hamstring stretching, as those are 2 of the most common tightnesses we see in athletes, as well as hip flexor and any other foam rolling or stretching that athlete may need based on their functional movement screen. The 2 outside sections, your core and pelvis stability and cardio and agility, are going to carry across almost every single plan you create, no matter the sport or athlete. The core and pelvis provide a base for all movement. So if there are weaknesses or instabilities here, that's when we're going to see inefficient movement and thus more injury risk. So by targeting these pelvic stability and abdominal strengthening exercises, we're going to see a greater efficiency in what the athlete does, so they're going to be less likely to have an injury. Then there's the cardio and agility aspect. We all know every athlete needs to have some sort of cardiovascular health, and when they don't, that's when we start seeing performance decreases or early fatigue, which leads to injury. So we want to add general cardio exercises, whether it be running, biking, elliptical, jump rope, whatever we can outside of their normal activity to increase their cardiovascular ability. We can also make these sports specific. That way they feel like they're still participating in their sport. So adding cone drills for soccer or football, doing hurdle jumps for track runners, whatever we can do to make them feel like they're getting better in their sport, but also working on themselves cardiovascularly. And then the 2 middle sections are going to be your more functional testing, what we notice there are weaknesses in. Your lower extremity from your hip down to your toe all works together in what we call the kinetic chain. So when there's one weak link, we're more likely to see weaknesses throughout all of it. So we'll address the knee and hip with strength and endurance activities. And it does create the stability for balance. So if you have a weakness in your glutes, you're more likely to have improper balance, and then your landing is going to be off, thus increasing more ankle and foot issues. So with them all working together, we want to target both the hip and knee and the ankle and foot with strength, endurance, balance, power, anything we can. And with the foot specifically, we often don't think about the little muscles that act within the foot. So we want to make sure that we target those little muscles with things like towel scrunches or marble pickups. That way we're truly integrating everything from the small muscles in the toe to the big muscles of the glutes and abdomen. That way, from your hips down, everything is strong and working together to provide the best possible experience with sport. So if an athlete or coaching staff is interested in something like this, they simply have to go to an athletic trainer, especially those of us involved in NovaCare. We can get a team together to provide some functional movement training for these athletes and put together one of these plans. So that way we see greater improvement throughout all of our athletes here in the greater Philadelphia area. And that's all I have.
Awesome, thank you. I know I saw some questions come up in the chat, so I'm hoping you guys I'll read them through and then you guys can field them based on who feels like they want to answer it. So Eve said, do you have any suggestions or information related to shin splints? I don't know if you can give some basic information on that.
So yeah, I didn't include that. So starting from the foot, working my way up as that's my bias. But but we do see patients with, with Shin Splints or related conditions, and that is a common issue with runners as well. In my mind, it's kind of, Shin Splints are more of a diagnosis of exclusion, meaning we have to rule out, other potentially more serious causes of pain. And the biggest thing would be like a tibial stress fracture. So if there's, point tenderness on the bone, a lot of swelling, I have a low threshold to get an MRI, especially if, if it's a patient or athlete looking to get back to play quickly. Other thing to consider is like an exertional compartment syndrome that typically has a little bit different history of, significantly increasing pain with activity, moreover the musculature rather than the medial aspect or the inner aspect of the bone itself. So those are some things that we're looking to differentiate. And if we have a suspicion for that, we can actually measure the compartment, the compartment pressures in the various compartments. But, once we kind of rule those things out, Shin Splints are often kind of more of a tendinitis or more of a stress reaction. And typically the treatment in my mind is almost exclusively like physical therapy, stretching, strengthening exercises. So I do refer those patients, for therapy to get them back to play.
Greg asked, a lot of the topics in this discussion are soft tissue and tendinopathy related disorders. I wonder if the presenters could discuss the pain modulation model and how discussions are presented to patients in regards respected soreness. In some cases, actually provoking some forms, some forms of discomfort to help them return back to sport, i.e. Achilles tendinopathy, also address patient buy-in.
Yeah, so, I think that's probably an important area in this all, though not something, that as like an orthopedic surgeon, our training is really geared toward. Maybe it should be more geared towards that. So, from my standpoint, it's more kind of evaluating the structural issues and treating those, via, non-surgical and surgical means. But, there certainly are times where there's pain that is not necessarily well explained by the structural pathology. And you're right in that, often this can happen with soft tissue conditions. So, I think physical therapy does play a role in that, including kind of desensitization types of modalities and exercises, and even, referral to pain management docs to help, treat these types of pains that aren't necessarily relieved by improving the structural aspects. But I don't know if the other, Zach or Kelly can speak to that as well.
As the person that typically does the first stage of the evaluation, we definitely do have to differentiate between athletes who are coming in with a true injury or pathology versus kids who are just sore and reporting whatever discomfort they feel. Sometimes it is explaining to an athlete that there's a difference between being hurt and being injured. There's a lot of work that goes into athletics, especially when moving up in levels. So that's when we typically see some sort of discomfort in activity. So we have to address that. Sometimes it does mean putting them through a preventative exercise program or rehabilitation to kind of implement a mental effect of returning to play versus not necessarily seeing all of the physical aspects. And as for the patient buy-in part, we really, I think, as an athletic trainer, find this to be the biggest part of my job is I get to know these guys on and off the field. So that's where we have to work on their mindset and get them to understand the steps of the process and how it will get them back and better than ever. So that's how I see patient buy-in is a lot of times they're not going to want to do it, but if they want to perform their best, they have to complete some sort of rehab to return to that spot.
Yeah. I also apologize. There was a second part to that question. Also, can the physician discuss his classification for Achilles tendinopathy and if he has all patients complete calf stretching or just mid portion, given the rate of fat pad involvement with the insertional Achilles tendinopathy?
Yeah, so the calf stretching is effective both for insertional and non-insertional tendinopathy, decreasing the tension on the Achilles in either area, or the related bursitis, which I think is also an issue related to tension on the Achilles and the associated friction between the bursa and the calcaneal tuberosity. So there's good studies to show that it's effective both for insertional and non-insertional Achilles issues.
How do patient conversations go with discussing expectations of continued pain for prolonged period with the tendinopathy on the physician end by oven the data on prognosis for tendinopathy, given the data on prognosis for tendinopathy? Sorry.
Yeah, I'm not exactly sure what this is referring to, but typically when we're dealing with patients, I'm kind of going through the algorithm of of how to get them better with these tendinopathies, including the Achilles, and it kind of runs through that treatment protocol, starting with the non-operative things, rest, with the mobilization, stretching, strengthening exercises, and then if progress is not being made, over 6 to 8 weeks, not to say that patients are going to be 100% improved over that period of time, but looking for for at least some improvement of symptoms, then we start to discuss other options, be it custom bracing, which is more relevant for patients who are lower demand, not necessarily runners, or considering surgical interventions, or some of those kind of semi-surgical procedures, such as the percutaneous tenotomy procedures that I don't personally do, but some of my colleagues do.
And I think the physical therapy can play a role in that as well. Whenever the tendinopathy is maybe a little bit longer prognosis, sitting down and having that conversation on the initial evaluation of expectations and rehab goals, and based on the expertise and how many patients I've seen with this injury, what the expected outcomes are and what the outline is, and giving them some feedback on when they're hitting those or when they're not hitting those, and how we can shake up the rehab progression or process to kind of address their concerns too. So
Awesome. And then I think we have 2 more. So what's best to do with knee pain after running? Anybody?
What was it? What was the question?
What's the best thing to do with knee pain after running?
it's pretty open. That's pretty open-ended.
It's very open-ended. Yeah.
Typically, obviously, the first line of defense is typically going to be something like rice. Inspecting the knee, first of all, is the first step. Is there swelling? Is there redness? Is there tenderness to the touch? If it's just some achiness or anything like that, icing, rest, and then maybe decreasing your load the next time you're out is probably the best option, or your first line of defense. And see if you were just doing too much too quickly. Take a look at the route you were running. Were you on asphalt for the first time? Were you on trail run for the first time? What your footwear was? Your shoes older? Are they a new pair of shoes? How many miles have been on them? Those are things to think about first. But yeah, just knee pain in general is a sort of an open-ended thing. But that would be your first line of defense, and see if that takes care of it before anything else.
Perfect. All right, and then one last one, and then we'll all get on with our evenings. Are there evidence-based RTS criteria used for the ankle, similar to HOP tests for the knee?
So, I don't think that the data is as strong as maybe for the studies they have on the knee, but I know that similar tests are used for ankle conditions. I know that like Bob Anderson, kind of the most well-known sports foot and ankle specialist, kind of quotes that as the HOP test as a specific return to sport criteria. I think he has them do kind of 15 hops and comparing side to side, and I try to do something similar. Also comparing single limb heel rise from one side to another. Those tend to give a pretty good sense of when an athlete is close enough, close to back to 100% that they're safe to return.
Thank you so much. Thank you, Dr. Fuchs, Zach, Kelly. Thank you, Natalie and Chris, who's our Regional Director of Athletic Training. I'm sure Natalie will put some information on how you can schedule an appointment with Dr. Fuchs in the chat box. And I put our information in there, novacare.com, or our central scheduling office, which is listed right there. So if you have any problems, you can call one of our 3 experts to help you fix it. Thank you all so much for joining us, and have a wonderful evening.
Thanks, everyone.
Thank you.
Thanks, everybody. Have a great night.